Hello, East Coast, West Coast, and around the world. My name is Adrian Dana on behalf of the ASMBS and the Bariatric Surgical Training Committee and my co-moderators. I would like to welcome you to this edition of the Fellow Project Series. And joining me this morning is Dr. Kunoor Jain-Spangler, and the West Coast session will be hosted by Dr. Judy Chen and the chair of our committee, Dr. Matt Martin. Our goal is to bring the world of bariatric surgical education together with high-quality didactics by content experts and over the course of the academic year to cover all the major topics for the ASMBS educational curriculum. Over the past 6 months, we've enjoyed a growing number of participants, and we welcome your questions to ensure that we get an interactive learning experience for our fellows and our faculty. As a reminder, please use the Q&A function of the Zoom app to enter your name, institution, and questions. We will get to as many questions as possible, and there will be a separate live Q&A session for the West Coast rebroadcast this afternoon. Also, a reminder that our next edition will take place on February the 5th, and that will be, the topic will be gastric bypass with Dr. Kelvin Higa and Dr. Shanita Johnston. Today, our guest lecturer really needs no introduction, but Dr. Phil Schauer is one of the most prolific metabolic bariatric surgeons in the world and a past president of the ASMBS. And Phil, by the way, when you were president, you were at my current age, which makes me realize how little I've accomplished. And he's been a pioneer and a trailblazer in our field and one of the first surgeons to refine the technique for gastric bypass. As a matter of fact, you are probably learning this operation from someone who was taught by Phil, or from someone who was taught by someone taught by Phil. He was also instrumental as a clinical researcher on the remission of type 2 diabetes and metabolic surgery, bringing us high-quality studies such as the STAMPEDE trial. Phil is now at the Pennington Bioresearch Institute Center at LSU in Baton Rouge, Louisiana, where he may be the first professor of metabolic surgery in the country. Despite so many accomplishments, he is just getting warmed up with a lot more contributions on the way. On a personal note, my respect and admiration for Phil goes beyond his contributions to our field. Dr. Vadim Sherman and I were actually his first graduating fellows at the Cleveland Clinic. We showed up to learn laparoscopic skills, but walked away with a passion for treating diabetes and obesity with surgical interventions. It's really a pleasure to introduce my mentor. Phil himself is currently recovering from COVID-19, and he will also bring us a small tribute to the father of bariatric surgery and some of the other monumental losses that we have suffered in 2020 in our discipline. He will review the evidence for metabolic surgery and inspire us with a look into the future endeavors in our field. Phil, the virtual podium is all yours. Take it away.
Adrian, thank you so much. It is indeed a pleasure and honor to speak to this group of fellows, and I can't tell you how important, how instrumental my fellowship was for me way back in 1994-95 at Duke University, and how it really steered me or my career in the direction it is today. So I salute all of you fellows out there. In some ways, I'm a bit envious of you because this field is just beginning to really mature, and there's so much excitement ahead over the next 10, 20, 30 years. So it's really going to be a phenomenal ride. Also, I want to salute Adrian and all those who are involved in organizing this fellows conference. This is really a fantastic way to distribute very important information to the fellows, as they proceed with their fellowship training. So what I'd like to do is talk about, I think it's a very important topic I think all fellows in this area should have a good understanding of, and that is, the evidence. What is the scientific evidence for metabolic surgery, both in terms of the current status and, where do we need to go in the future? Now, as Adrian had pointed out, I want to share with you my my new location. I'm in Baton Rouge, Louisiana. This is a kind of unique map that categorizes the rates of extreme obesity county by county, in the case of Louisiana, parish by parish. And the red dots have the highest rate of not just obesity, but extreme obesity. And you can see, where are most of those dots? They're right there in Louisiana, Mississippi, Alabama, these southeastern states. So our center is in the right location. We're, in fact, in the epicenter of the extreme obesity. And here's the Pennington campus. This is my new home. After 15 years at the Cleveland Clinic, took this incredible opportunity to come here and work with more than 200 scientists who have devoted their entire careers to understanding better these dreaded diseases of obesity and diabetes. And we've just set up a new bariatric and metabolic institute on the campus, which for the first time in 30 years history of Pennington will now actually not only study, but will actually treat obesity and diabetes. So we're very excited about this opportunity. And if you're ever in the area, please come by, stop by and see us. We'd love to show you our campus and our center. These are my disclosures. I don't think any of these have any particular conflict with today's presentation. Now, I wanted to begin with a very important recognition and tribute to a person who many believe is the father of bariatric metabolic surgery, Dr. Ed Mason. Many of you are probably aware that Dr. Mason just passed away just a few weeks ago at the ripe age of 100. He lived a very long, very fruitful life and accomplished much in his area, and really deserves credit for really establishing bariatric surgery as a legitimate clinical field and scientific endeavor. If you want to know more about his life, please go to the ASMBS website. There's a very nice tribute to Dr. Mason, who is well known as the inventor of the gastric bypass, the vertical banded gastroplasty. He started ASMBS. At that time, it was called the American Society for Bariatric Surgery, and many, many other accomplishments. He just passed away and definitely deserves an important tribute and recognition. Now, as I get into my talk, I want to begin by pointing out the two most common, important killers of not only Americans, but people in the entire Western Hemisphere. That is heart disease and cancer. Now, with heart disease, through various advances, smoking cessation and advanced treatment and prevention of heart disease, over the last half century, we've actually made some progress. However, it looks like that progress just in the last 15 years has been stalled quite a bit and looks like it's almost on an uptick and increasing. In addition, we have cancer, which has steadily risen over the past more than half century and appears to be continuing to rise despite our efforts. Now, many scientists, investigators believe that the reason that these two diseases are not improving in terms of their lethality is due to the obesity and diabetes epidemic. That's right. Obesity and diabetes are major risk factors, not only for cardiovascular disease, but also for cancer. And I think everyone is fully aware of this incredible obesity epidemic we are in the midst of. And it looks like that it is increasing unabated. By 2030, if trends continue, it looks like 1 in 2 adults in our country will be considered obese. So this is an extraordinary issue, and obesity is an extraordinary driver of the two biggest killers of Americans today. Now, it turns out, and I'm going to show you strong evidence that metabolic surgery, bariatric surgery, may in fact be the most effective treatment for cardiovascular disease and cancer prevention. Now, all of you familiar with bariatric and metabolic surgery. Shown here are the 4 common operations performed throughout the globe today: the sleeve gastrectomy, the gastric bypass, gastric banding, duodenal switch. Shown below each procedure is the relative usage of these procedures, and there's many other permutations of each of these operations. Remarkable trend over the last decade or so has been the incredible reduction in complications and mortality of these operations. And I think this slide illustrates very nicely the relative safety of bariatric surgery, shown at the very bottom, the laparoscopic gastric bypass, compared to other common operations. This data comes from a very, very large database from the American College of Surgeons, which indicates the perioperative morbidity and mortality associated with these procedures. At the top of the slide, you see coronary artery bypass surgery, which has nearly a 50% complication rate within 30 days of the operation. And then going down that list, you see operations in green, which are considered relatively safe, low-risk procedures, such as cholecystectomy, hysterectomy, and gastric bypass. And you see that laparoscopic gastric bypass and similarly sleeve gastrectomy, are now considered relatively low-risk procedures. So this is very important information to be aware of as we address the relative risk and benefits of these operations. Now, most of the talk today, I'm going to focus on what is the evidence to support metabolic surgery as a treatment for cardiovascular disease and cancer. And I want to just go back to the basics just for a moment and talk about how we categorize evidence. I'm sure all of you, hopefully by now, are quite familiar with this weight of evidence designation. So level 1 evidence comes from high quality, multiple randomized controlled trials. Level 2, which is a step down, would be lesser quality randomized controlled trials or other comparative type studies, prospective comparative studies. Level 3 are case control. This is where you have essentially retrospective comparison of 2 types of treatment where there's an attempt to match the groups to try to achieve some type of equivalency in terms of the comparison. Then level 4 case series. That's a typical before and after type of experiment where you subject a group of patients to a treatment, you measure their status before the intervention and after, but there's no comparison. And then finally, there's expert opinion, which has the lowest level of evidence. So these are the degrees of evidence that we have for comparison. And by far, level 1 evidence is the most important and the gold standard. The randomized controlled trial is king. It is the very best trial model to minimize bias. We talk about bias, what we're talking about are influencers of outcome. And a randomized controlled trial attempts to equally distribute within study populations factors that may influence the outcome. And you can divide these outcome influencers into 2 groups. Those that are known outcome influencers, for example, obviously age, body mass index, diabetes, high blood pressure. These are all factors that we know influence cardiovascular outcomes, heart attack, stroke, and death. The older a patient is, the more likely they're going to have a heart attack. Body mass index, diabetes, and also the severity of diabetes. These are all known influencers. And to some extent, we can actually measure these after randomization and ensure that all groups who are randomized have similar proportions. But equally important are the unknown influencers, okay? These are things that either are hard to measure, for example, socioeconomic status, which we know that's an influencer. People who are high socioeconomic status are more likely to do better with any type of treatment than someone with lower socioeconomic status. That's hard to measure. And then there are factors that we just don't know. There may be genetic factors. There may be other factors that we just don't know yet that are major influencers, okay? Now, by random allocation of a population to different treatment groups, we can ensure that both the known and unknown influencers are relatively equal in all groups, particularly if it's a large sample. The larger the sample, the more likely that all groups who are undergoing a specific treatment for comparison are going to be equivalent. And this is very, very important to eliminate bias. Okay. Now, in addition, I also want to drive home this other important point. There are lots of different types of randomized controlled trials, but in general, two types. Those that measure biomarkers of disease, that is, markers of disease, such as weight, blood pressure, A1C, where the actual outcome that is measured is one of these markers of disease. Now, these types of studies generally don't require as large a sample to measure because it's very easy to demonstrate differences statistically in body weight, blood pressure, and A1C. And these markers are generally have been shown to correlate with hard disease endpoints, okay? Now, the other type is an outcome measure that would be considered an actual hard clinical endpoint. And this is a much more robust endpoint: myocardial infarction, stroke, and death. At the end of the day, this is what patients and doctors want to know. They want to know, does treatment X reduce my risk of a heart attack, stroke, or death? They're not so concerned about whether that treatment reduces a blood test like A1C, even though A1C does in general correlate with the reduction in heart attack and stroke, but they want to go right to the key endpoint, okay? So those are called, a randomized controlled clinical trial with hard endpoints. And these are much more difficult to do and generally require a much larger sample size because you have to follow a large number of patients over time before you actually see these events occur: heart attack, stroke, and death. Okay, so hopefully I've made this distinction very clear to you because it is very, very important in understanding clinical evidence. Now, let's jump right in and look at what we have, the evidence for metabolic surgery in terms of randomized controlled trial. And I must say that in the last 10 years, this has been a huge advance in our field. Prior to 10 years ago, we didn't have any randomized controlled trials, essentially, showing that metabolic surgery is more effective than medical treatment for diabetes or for obesity. Now we have an abundance of studies. Let me just start with the trial I'm most familiar with, and this is the STAMPEDE trial. This is a randomized controlled trial that was initially published in New England Journal of Medicine 2012, showing the 1-year initial results. Then the 3-year intermediate results were published in 2014. And then in 2017, the longer term 5-year outcome were published. And this was supported by Ethicon and NIH and was conducted at the Cleveland Clinic. Now, let me just share with you the trial design. There were 3 treatment arms, and 150 patients were randomized to one of these arms. The first arm is intensive medical therapy. This included standard ADA guidelines for treating diabetes. The goal was to use medications to drive the A1C to 6% or less, and patients had very frequent visits and interventions by a multidisciplinary team of endocrinologists, psychologists, dietitians. The other treatment arm, where patients were randomized to gastric bypass, and then the other treatment arm to sleeve gastrectomy. And these 2 surgical arms also, of course, included medical treatment. But in general, after the intervention started, medications were actually decreased over time, whereas in the medical group, medications were actually increased over time to reach those key targets of therapy. Now, here are the baseline characteristics. And going back to my previous slides about randomized controlled trials, it's important to show that in all 3 groups, these key factors, known factors, are relatively equal in all 3 groups. And we did see that, okay? It's also important to note that in this trial, patients had fairly advanced diabetes, okay? In terms of their age, and in terms of the duration of diabetes, they had 8 years or more on average, and their A1C was above, was almost 9 in these 3 groups, and the body mass index was about 36. And these patients, on average, were on 3 or more diabetes medications. So it shows you that they had fairly advanced diabetes. And that's important to know because any treatment is less likely to be effective in patients who have more advanced disease, whether it's medications or surgery. So important factor to know when you're interpreting the data. Okay, so here's the data. This is probably the most important slide. And it shows you the primary outcome, which was change in A1C over time. And you can see here that both surgical interventions were much more effective over time in showing a drop in A1C from baseline over the 5-year period compared to medical therapy. Now, with medical therapy, we did see an improvement initially as our endocrinologists began to add more medication, but it was very hard to sustain that improvement over the 5 years. And in fact, at the end of 5 years, patients were essentially back or almost back to their baseline A1C at the 5-year period. So at the end of 5 years, most of the patients in the medical group were no better off. In fact, there were more that were worse off than those that were better off. The surgical group, however, the vast majority over this 5-year period were much better off. A few were unchanged, and very, very few were worse off compared to the start. So very, very important finding here in this randomized controlled trial. Now, another important factor that's probably a big driver of the improvement is the change in body weight. And you can see here the BMI dropped significantly in both the bypass and sleeve gastrectomy group, whereas there was just a modest improvement in BMI in the medical treatment group. And here we also saw a statistical difference favoring gastric bypass over sleeve gastrectomy in terms of weight reduction in this outcome. Now, this is one of the first studies to also look at lower BMI, and we separated patients, those that had a BMI less than 35 and a BMI greater than 35. And as this graphic shows, that even patients with a BMI less than 35 who had surgery, they enjoyed a very similar improvement in A1C as with patients with a BMI greater than 35. And this is one of the first studies to show that a BMI as low as 27 may benefit from bariatric surgery in terms of improving glycemic control. We also looked at medication usage, and this is also very important. In addition to A1C, you have to also look at medications being used at the time. And when you break it down into these three groups, you see at the end of 5 years, in the medical group, most of the patients were still on insulin and oral agents, whereas patients who had gastric bypass, 45%, nearly half of them were completely weaned off their diabetes medications. And sleeve gastrectomy also had reduction in medications, not as much as gastric bypass. About 25% were able to be weaned off their medication. So surgery improves glycemic control and reduces medication dependency. So very, very important findings here. We also saw the same pattern not only with diabetes medications, but with other medications such as lipid-lowering agents, as well as antihypertensive agents were reduced after bariatric surgery compared to medical treatment alone. And then finally, we looked at quality of life. This is a quality of life instrument known as the RAND Corporation SF36. And you can divide this into two key domains: physical health, mental health outcomes. And here, let me just get to the bottom line. We showed that in this study, quality of life was improved overall after surgery 5 years later, but no change, or in some cases actually worse, 5 years after medical therapy. So a very important outcome measurement too is quality of life, in addition to those other biomarkers of disease. Now, in addition to the STAMPEDE trial, there now are 12 randomized controlled trials that have looked at these biomarkers of disease, not hard clinical endpoints, but biomarkers of disease, such as hemoglobin A1C. These studies include a variety of different procedures: gastric bypass, sleeve gastrectomy, gastric banding. Most of these studies are relatively small sample size. STAMPEDE was the largest, 150. They vary anywhere from about 50 patients up to 150. Follow-up is now 4 studies that have 5-year follow-up. Most of these, the primary endpoint was change in A1C or diabetes remission. And all of these, except for one, shows a statistically significant difference favoring metabolic surgery over medical therapy. The one exception is the third from the bottom by Ding and others. This was gastric banding compared to medical treatment, and that did not show a statistical difference, but all of the others did. So very consistent evidence favoring metabolic surgery, at least in terms of a biomarker endpoint. And here's the STAMPEDE trial, which is one of the first and the largest study to date. Now, in addition to these 12, I'm going to quickly show you 2 other studies that were just published in 2020. And this one by Ricardo Cohen and his group in Brazil shows the effect of gastric bypass versus medical treatment, looking primarily at renal function. That is the rates of nephropathy as determined by urinary albumin creatinine ratio at 12 months and 2 years following surgery. And you see here a much greater improvement, reduction or remission of albuminuria in the gastric bypass group versus best medical therapy at 2 years. And also in this graph here on the right, you see a much greater improvement in urinary albumin creatinine ratio favoring gastric bypass compared to medical treatment. This was very intensive medical treatment. And then we also have another study, also from Brazil, looking at 3-year outcomes of bariatric surgery compared to medical treatment for hypertension. And this showed that there was a greater than 30% reduction in medication usage and lowering the blood pressure below 140/90, favoring metabolic surgery versus medical treatment. 73% versus 11%, which is a highly statistically significant difference, and a 31% remission of hypertension versus 0% in the medical group favoring metabolic surgery. So now we have 14 randomized controlled trials. But remember, all of these trials so far that I've mentioned are using surrogate markers, biomarkers of disease, not actually hard clinical endpoints. Now, let's talk about hard clinical endpoints, true measures of morbidity, mortality. And with diabetes, we're talking about macrovascular changes such as heart attack, death, stroke, but also microvascular changes such as renal failure, dialysis, blindness, so nephropathy, neuropathy, and these types of microvascular endpoints. And this table shows very nicely that there are now actually more than 28 observational studies. These are retrospective comparative cohort studies comparing metabolic bariatric surgery versus medical treatment. They're not randomized trials, but they're published in very high impact journals such as JAMA, New England Journal of Medicine, Lancet, Diabetes Care, Gastroenterology, and all of these studies, without exception, show a significant mortality benefit favoring surgery. And after all, mortality is arguably the most important clinical endpoint of any treatment. And on average, these studies show about a 45% reduction in overall mortality favoring metabolic surgery. Okay, so very, very significant data. Now, I want to share with you one of the more recent studies that came from the Cleveland Clinic that I was involved with, and Aliyah Minion, a colleague at the Cleveland Clinic, was the first author on this study. And let me jump to that right away. And this study compared more than 2,000 patients we operated on over a 15-year period who had diabetes, compared to over 11,000 patients who had diabetes and obesity, but did not have surgery. And these were matched for key known factors such as age, BMI, degree of diabetes, age, and other key factors. So it was a retrospective matched cohort study. Again, not a randomized controlled trial. And here are the major outcomes. We looked at 6 components, which is a composite of death, heart attack, myocardial infarction, stroke, onset of nephropathy, and atrial fibrillation. And here you can see with this composite endpoint, composite MACE, that patients who had surgery had a much lower rate of developing those endpoints than the non-surgical controls. And we saw similar findings when we looked at a 3-component MACE, that is the 3 major indices of outcomes: death, heart attack, and stroke. Surgery had a much lower risk compared to those. And these are hazard ratios of 0.62, which is quite a remarkable hazard ratio favoring surgery. Now, in summary, this study showed that metabolic surgery was associated with a 41% reduction in death, 62% reduction in heart failure, 31% reduction in heart disease, 33% reduction in stroke, 60% reduction in nephropathy, and 22% reduction in atrial fibrillation. And by treating just 13 patients, you can save 1 life. And that number needed to treat ratio is extremely high. Treating only 13 patients, you actually save a life, which is remarkable. And here's a conclusion of that study, which was published just last year, or 2019, in JAMA. And the major conclusion at the bottom is that these findings from this observational suggest we need confirmation in a prospective randomized clinical trial. Now, I also want to point out, just a few months ago, in October 2020, we have the 20-plus year outcomes of the Swedish obesity subject study. And I'm sure most of you are quite familiar with this long-term prospective observational study comparing various types of bariatric surgery with just standard medical treatment And on the left, you see the changes in body mass index, but the graph on the right shows the survival curves. And you can see here that those who had metabolic surgery, bariatric surgery, and this included mostly vertical banded gastroplasty, Dr. Mason's operation, which is not very commonly performed today, but nevertheless had a superior survival compared to those who were treated just medically. And this follow-up actually goes out to nearly 40 years. So it's a very, very impressive study. However, again, the major criticism of this study is not a prospective randomized controlled trial and is subject to all the criticisms of such a study. So this study showed that a hazard ratio of 0.7 for death from cardiovascular disease and 0.77 death from cancer. So cardiovascular disease and cancer death reduction were the major contributors to overall reduction in mortality in this particular study. However, we need validation in a randomized controlled trial. Okay. And here's another study that was just published just a couple weeks ago. And for the first time, looking at the association of metabolic surgery with cardiovascular outcomes in patients with pre-existing cardiovascular disease. So we call this secondary prevention. These are patients who had previously had a heart attack or stroke and underwent metabolic surgery or medical treatment. And in this group, you also see a significant reduction in overall heart attack or stroke compared to the control group. So the evidence is certainly mounting, but we still need prospective randomized controlled trial data. And if you'd like to know more about why a randomized controlled trial is so critically important, here's a very nice review paper by my colleagues Aaliyah Minion and also Steve Nissen, who's one of the foremost cardiologists. He is the chair of cardiology at the Cleveland Clinic, and it goes through step by step, why we need a prospective randomized controlled trial in our field to really unequivocally show whether or not a metabolic surgery actually leads to cardiovascular risk reduction. Now, before I finish, I do want to just briefly comment about the other major killer, and that is cancer. And all of you are probably familiar with the association between obesity and cancer. In fact, there are 13 cancers that are clearly associated with obesity, as shown here. And there are a variety of reasons why obesity is associated with cancer. If you want to know more about the carcinogenesis effect of obesity, here's a nice review paper that shows you the association of obesity and alterations in angiogenesis, apoptosis, and proliferation or cancer cell survival, leading to tumor development. It's very, very interesting information. Basically, inflammation leads to cancer, and obesity causes inflammation. Now, finally, I want to share with you 12 studies that have shown that metabolic surgery is associated with a reduction in cancer risk development. And here's a forest plot showing these studies. There's an overall hazard ratio of about 0.56, which is quite significant, showing very significant reductions in the development of new cancer over time in patients who had metabolic bariatric surgery versus control groups. But this is, again, strictly observational data, and there's yet to be a randomized controlled trial of any type demonstrating this important finding. So what are the future directions? So hopefully I've made the case to you that what we really need to do to move our field forward, to end any dispute, we need a multi-center randomized controlled trial with hard clinical endpoints. And in fact, every treatment that has a cardiovascular benefit claim, whether it's a drug like a statin or an ACE inhibitor or a GLP-1 or an SGLT2 inhibitor. All of these drugs have been subject to multi-center randomized controlled trials with hard clinical endpoints and have shown a reduction in those MACE, major adverse cardiovascular event rates, okay? Procedures, coronary artery bypass, carotid endarterectomy, aneurysm repair. These are all studies that have shown a cardiovascular risk benefit in a randomized controlled trial. And they have key claims. And this is why those types of procedures are recognized by every insurance company, essentially, and offered as legitimate treatment. With metabolic and bariatric surgery, we have zero in the 50-year history, more than 50-year history, going back to the early days when Ed Mason really developed the field in the 50s and 60s. We have zero multi-center randomized controlled trials with clinical endpoints showing whether or not metabolic surgery actually reduces cardiovascular disease. So this is what we need to do to move our field forward. And I'm convinced that if this study is positive, it has a very high probability of being positive, but we don't know that. This will move our field forward and will address many of the current problems that we have with utilization of surgery. As all of you know, less than 1% of people who qualify for surgery are actually getting it, okay? And that's because there are doubts among referring physicians, there are doubts among patients, and there are doubts among the payers that surgery really does achieve those endpoints. So what would a study look like? Well, a number of investigators, including myself, for the past few years have been working on developing a trial. And the time being, we're calling this trial DREAMS. This is actually my dream trial. And that stands for Diabetes Reduces Effectively After Medications or Metabolic Surgery. And essentially, this trial will be the definitive study that will include patients who have severe obesity, type 2 diabetes, and a proportion of them will have pre-existing cardiovascular disease. And that's all intended to enrich the sample size to increase the probability of having an event. And that allows us to have a reasonable sample size and reasonable follow-up, okay? So this study will randomize patients with that inclusion criteria to either metabolic surgery, the two most common types, sleeve gastrectomy and gastric bypass, versus standard medical therapy, and will follow patients for 5 years. And we think this trial, which will have a sample size of about 3,000 patients, will be able to tell us at 5 years whether or not metabolic surgery does indeed reduce the risk of major cardiovascular adverse events, heart attack, stroke, and death. In addition, by extending the follow-up a bit longer, we can also look at rates of cancer development over time, okay? So this study could potentially address two major areas, two unknown outcomes. Does metabolic surgery reduce cardiovascular morbidity and mortality? Does metabolic surgery reduce the rate of onset of cancer? So two very, very important questions that are quite relevant because these are the two biggest killers today. So as I conclude, let me just point out again that we do have quite an abundance of evidence showing that metabolic surgery is more effective than medical treatment for glycemic control, weight loss, blood pressure, nephropathy, metabolic surgery is relatively safe. It's about as safe as having a cholecystectomy or hysterectomy. And we have an abundance of observational studies that are quite consistent in showing metabolic surgery reduces morbidity and mortality of cardiovascular disease and new onset cancer. But what we don't have is a definitive trial, a randomized controlled multi-center trial that looks at hard clinical endpoints. And this is what we need to move our field forward. So again, I want to thank all of you for your attention. And if we have some time, I would be very happy to address any questions that you might have. And let me again thank Adrian and Kunoor for the opportunity to present to this group. Thank you very much.
Phil, this was fantastic. And I will start with a question that I have, and I think Kunoor's got something lined up too. I remember attending a session on with Dr. Schoenstrom on the Swedish obesity subject study. And someone mentioned that if you take the mortality curves out long enough, they're going to come back together. So can you comment a little bit? Most of the studies, the observational studies that you pointed to, the 40 to 45% decrease in mortality, that occurs pretty early on, even within 5 to 10 years. Is that correct?
That's correct. It's a really astute question, Adrian. And in fact, the separation of mortality happens very early, actually, even within the first year. And that includes the operative mortality, which is extremely low. I mean, and that's another huge accomplishment of our field. Back in the days of Ed Mason, his initial mortality rates were in the 5% range. And they are now down to 0.1%, which is remarkable. So the separation of mortality in the SOS study is in the first 6 months. By 6 months, even with the operative mortality, patients in the metabolic surgery group are doing better, have greater survival. But yeah, you're right. Eventually, if you go long enough, the mortalities curves will converge. Why is that? Adrian, everybody dies. In the history of mankind, no one's gotten out of this alive. Okay, we all die. Okay, so what it really means is, can an intervention extend your lifespan? Okay, and with these observational studies, it looks like metabolic surgery can extend your lifespan by about 7 to 10 years, which is quite significant. There are a few interventions, surgical or medical or otherwise, that extend your life that long. Okay, so that's the point. Yes, eventually, all mortality curves will converge, but the key is, how much additional life expectancy can you achieve with intervention?
So another quick point to touch on, what the pharmacologic therapies have is also a lot of money, and they actually do have prospective cardiac vascular outcome trials, but their reduction in mortality, can you comment a little bit on that? What is it?
Yeah. So you're right. I was recently at a cardiology conference, and a cardiologist said this, or a cardiologist endocrinologist. He said, Phil, because I presented this data, he said, endocrinologists, we start dancing in the street when we see mortality reductions of 5%, 10%. And he said, you have shown us that metabolic surgery achieves 45%, with the observational data, which is basically 5 times greater mortality reduction. I mean, that is extremely remarkable in terms of the relative changes. Coronary artery bypass, it does have a mortality benefit, but it's modest. It's in the 5 to 10% range, and it's only for patients that have critical left main disease, you see. And that's an operation, Adrian, that costs about $70,000 and has an operative mortality in the 1 to 2% range. Okay? So it just, again, shows you the relative benefit cost benefit of metabolic surgery compared to other medical and surgical treatments. But we have to validate this with the randomized controlled trial.
Well, I just wanted to say thank you again so much for your, not only your contributions, but providing your insight today in this incredible lecture for our fellows. Kind of moving, I also have a couple questions. I recently have delved into the somewhat humbling world of the duodenal switch, and was just wondering what your take is. When you think about the duodenal switch, or now a lot of people will be doing the single anastomosis switch, was that something that you would incorporate into the DREAMS trial? Although it is, you know, a pretty complex or more complex operation and can have a higher complication rate, we also see that the results are incredible. You know, I'm now personally seeing this. The data is certainly there, albeit slimmer than the bypass or sleeve data. What are your thoughts on that?
Yeah, so it's definitely an important procedure. It definitely has a role. It's clear, and there are some randomized controlled trials comparing duodenal switch versus gastric bypass, sleeve gastrectomy, medical treatment, especially by Gertrude Mangroni and Francesca Rubino, you know, clearly showing, you know, with biomarkers that it's more effective for diabetes, for glycemia. There's no question about it. But there's also no question that it has a higher risk of nutritional deficiency. So you have to balance those. So you know, in my opinion, I clearly think it has a role for those patients with more severe obesity. When you start getting into, you know, BMIs above 60, you know, the most we get from gastric bypass or sleeve gastrectomy is about a 15 point BMI reduction. Okay. And with duodenal switch, you can get much greater weight reduction, which is a key driver of healthcare, of health benefit. So I do think it has a role. It is higher risk, and it does require a lot more preoperative preparation by the patient and long-term follow-up. Now, should it go into the DREAMS trial? Well, you know what? We don't have a strong enough evidence of that procedure, and it does complicate the study quite a bit by adding another treatment. So I do think eventually that type of study should be done. But right now, we just need a definitive trial that includes the most commonly performed procedures that have demonstrated efficacy.
Thank you. One more question. So we've talked a lot about genetics today. So when you talk about inflammation and cancer and diabetes and obesity, how do you see this interplaying when we think about the eventual or 10, 20, 30 years down the future? Are we going to be choosing a surgical type based on a patient's genetic profile?
It's a great question, Kunoor. You know, there's been so much work, identifying, genetic factors, in the GWAS studies, trying to isolate specific genes for obesity and obesity outcomes have been unfruitful. I mean, what we know so far that there are, multiple genes, hundreds of genes that interact. So our ability so far to isolate any specific genes or markers has been, relatively limited at this point. So, obviously more work needs to be done in this area.
Awesome. Thank you so much. We look forward to hopefully seeing you, hopefully in person sometime in the near future. Until then, please stay safe.
Thank you, Kunoor, and thank you so much, Phil, and thank you everybody at the ASMBS. We look forward to the afternoon session and the Q&A for that, and to next month's lecture. Thank you everyone for joining. Fantastic lecture, Phil.
Thanks, Adrian. Thanks, Kunoor. It was a pleasure, and best of luck to all of you fellows out there. Again, I'm envious of you in many ways. You've got many of you 20, 30, 40 years, maybe more, if you live to be as long as Ed Mason, to work in this area. And I can't think of a more exciting field in surgery than metabolic surgery in terms of its potential impact on human lives. So best of luck to you, and hope to see many of you in the near future.
Thanks once again. Take care, everyone. Stay safe.
Hi, Dr. Schauer. Judy Chen here at the University of Washington, and I am so incredibly thankful that you have given expertise and your experience in such monumental, it's overwhelming the impact you've had, and we just thank you so much for your time today and that fantastic lecture. I would like to start off with a question, and I appreciate you sharing your dreams study. So exciting. In regards to metabolic surgery, what do you define that as? As we know, there's the sleeve, the bypass, and of course, versions of the DS that you have described in the beginning of your presentation. How do you sort out the differences in that under the umbrella of metabolic surgery?
Yeah. Well, hi, Judy. It's a pleasure to be here. I see Adrian as well. And thank you guys for inviting me. I love to talk to other surgeons about this exciting field, especially young surgeons like all of you out there. This is such an exciting field, and congratulations to all of you who have chosen, MIS bariatric as your field, because I'm very confident the next decade or 2 or 3 are going to be extremely exciting. So there's going to be so many cool things happening in this arena. So your question, Judy, is very relevant. So metabolic surgery, there's a long history of that term. And let me just give you a Reader's Digest version. I'm not sure who was first, but it might have been Walter Porres, who we call, Ed Mason, the father of bariatric surgery, but Walter Porres may be the father of diabetes surgery. But he introduced that term, a while back, and many years ago suggested that we actually change the name of our society, to American Society for Metabolic Surgery. And the first attempt didn't work. And when I was president in 2007, we made another attempt at it. And we thought at that time, there was enough evidence to really support that concept. So from 2007 on, we became ASMBS. And, I'm very proud of playing a role with many others in achieving that. Now, today, I think metabolic surgery applies to all bariatric procedures. I personally think at some point we might just drop bariatric. It has, in the minds of some people, older physicians, some patients, it may have a potentially negative connotation. I think all operations are metabolic, whether they work principally by weight loss or have other weight independent effects, but they all have metabolic effects. By metabolic meaning they improve diabetes, they improve metabolic disease. And metabolic disease is not just diabetes, hypertension, dyslipidemia, sleep apnea, NASH. All of those are metabolically orientated, conditions. So, I think we should eventually, my opinion, we should eventually go with using metabolic surgery and just dropping the bariatric, because I think it encompasses much more than just weight loss. It encompasses concept of we're improving, resolving metabolic disease.
So to look at your surgical arm, would you have some of those modified duodenal switch in your dream study?
Well, that's a great question. That was brought up this morning too. Kunoor, from Duke brought that up. It's a great question. It's a very good operation. It's not utilized very much. Only 1 to 2% of all operations. There's a lot of practical issues in that regard. There are not a lot of surgeons who are already trained and have a lot of experience in it. It does have a different risk-benefit profile. And there's no question, if you look at the operations and rank them according to which is most effective for diabetes, the duodenal switch is more effective than the gastric bypass, no question.
Right.
But it does also have higher risk, particularly with the long-term nutritional consequences. So I think for that reason, it's just probably not practical to include that in the study. But I do think there's definitely an important role for it.
All right, and if we switch to the medical arm, what is your standard medical therapy? Will that include the new injectables and technically oral GLPs and those elements?
Yeah, Judy, that is one of the most challenging aspects of the entire study, because it's an entire spectrum. The surgical procedures are pretty standard. If you're going to get a bypass, you're going to get pretty much a bypass or a sleeve, right? But medical therapy varies anywhere from like extremely intense, where the patient is on a GLP-1, SGLT2, ACE inhibitor, statin, weight loss medication, whereas it could be on the lower side where you're just on just essential drugs, right? And everything in between. So there's an incredible spectrum. And then we get into this practical issue for people in this study. Since so far, pharma hasn't stepped up to provide the drug, and the our funders that we're talking with don't provide funding for the treatment, that we're going to be pretty much subject to whatever insurance, whether it be public, Medicare, or commercial insurance, we're going to be limited to what they will cover. But I will point out, though, that even today, in patients that have insurance that covers many of these therapies, a lot of them are just not on all the drugs they should be on. Okay, so we do think that this can be ideally, a medical arm that is definitely a bit above and beyond sort of standard kind of community care.
I think you are pointing out the phenomenal work you're doing, right? You are going against so many things that we want to address in our field, our specialty. I'm so appreciative of the excitement you share. I do want to just say that your work is so phenomenal, and I just cannot thank you so much for sharing your experience.
Well, Judy, thank you. That's very complimentary, and I appreciate that. And it's always nice to hear nice things about oneself. But you know what? There's no question. I am standing on the shoulders of the Ed Masons, the Walter Pories, the Henry Buchwalds, the late Dr. Scopenaro, who just passed away this year, and also the late Harvey Sugarman. This is a tough year. We lost three giants: Scopenaro, Sugarman, and Mason this year. And I wouldn't be able to do anything without them. And I'm really excited to see what your generation is going to do, and take it to the next level. And Adrian's, Adrian is already, leading the way in so many different areas, especially on the education side. It's great to see that as well. So there's so much. This is still a young field. Okay. There's so much else to do. There are other fields, to me, seem to be kind of mature, that have a lot of the exciting advances may have already occurred, but not this field. This is really exciting.
Yeah, no, I want to thank you too, because sorry, Adrian. I just want to say that you're so wonderful, because I've emailed you previously to ask things, and you're very open to talking. So I just want to say thank you for being so available, and you're holding up the rest of us. So you are absolutely.
I mean, Adrian knows I love to teach and train. I've been blessed by being able to train 100 fellows, and many of them, most of them are famous, like Adrian, and Dr. Ninh Nguyen, who's the chairman of surgery at UC Irvine, and Dr. Saeed Akramanin, who's chairman of surgery at Minnesota.
No, I definitely don't mean to, I just want to share with, I've been out for 7 years after my fellowship, and it is scary to kind of hear your name and other names, but I just do want to share with our audience that you are available, which is so fantastic. Thank you. I've experienced it. And our field is wonderful that way. And I'm so glad for ASMBS and Adrian. Everyone is just fantastic. And I hope our fellows and everyone, as you say, really do take this opportunity to ask questions on Q&A and chat. So sorry, Adrian.
No, that's okay. I just wanted to echo the same things that you guys were saying. Phil, we are definitely standing on your shoulders. And I can't say enough about what inspiration you are to all of us. So this is great. This is what this program is all about. I would like to say that just being mentioned in the same sentence with Ninh and Dr. Kramadine, I don't think I deserve that kind of mention compared to what those guys have done, and we're standing on their shoulders also. I do want to ask you a couple questions, and this gives me a chance to remind our attendees that the morning questions, we really don't want to repeat those. They will be archived on the ASMBS website, where you can watch the lectures again as many times as you want, and you can also let other people who have not been able to watch them, you can let them know that they're available there. But Phil, I'm going to ask you a little tougher question here, and then follow that with another one. The first one is, with the abundance of data that we have, it's sometimes not the doubters, but it's sometimes the believers that say, Phil, how can we randomize a patient who qualifies a surgery to a therapy that we know to be less effective?
Yeah, great question. And there are a number of surgeons who believe that we've already answered the question. But, you know, again, Adrian, you know this as well as I do. We're 1%. What therapy that has the potential, I just showed you this slide where, 45% mortality reduction, 60 plus reduction in heart failure. And I mean, the list goes on and on and on. But what therapy that has that potential benefit is used 1% of the time? None. So, again, this world of surgeons that we live in is a very small world, compared to everything outside of our little universe. Primary care doctors, patients, and payers, okay? They don't see it the same way as we see it, and the level of evidence of certainty in their mind, and it's true for most treatments, is much higher. We're fortunate, we see patients every day. We witness in our follow-up clinic, it's one thing that's great about our field. In most surgical specialties, who wants to go to clinic, right? That is when we have our happy time, because our patients are coming back, their diabetes is gone, they threw away their walker, they threw away their CPAP device. I mean, it's just all happy time, right? So we see it every day, right? But the primary care doctors, they don't see that. And patients, are scared, and the payers, they have a different perspective. So we need, and it's doable. We've already have the proof that you can randomize patients. There are 14 small randomized trials. We know we can do it. We know we can put this together. And every other surgical procedure that claims a cardiovascular benefit, coronary bypass, stents, carotid endarterectomy, they've all done it, okay? So we can do this in an ethical way, and it's what needs to be done, and it needs to be done, now, not 10, 15, 20 years from now, because we're going to stay at this plateau if we don't do it.
So these wouldn't be patients seeking bariatric surgery. These would be patients with cardiovascular disease.
Right. So as you know, Adrian, we're only doing 1%, okay? So we're seeing 2% because 1%, half of them drop out because they don't have insurance or other issues. So we're seeing 2%. We're only operating on 1%. Okay. So we want to randomize the 99% who are on the fence, who don't know about surgery, or their doctor hasn't recommended it or suggested it. That's the group that we'll randomize. And we think there is this term called equipoise. We think there is equipoise, with modern medical treatment. The SOS study, for example, was conducted, back in the 80s and 90s. Then there was, no drugs, or virtually no drugs for, cardiovascular risk reduction. So surgery needs to be compared with some form of, modern medical treatment. And we think there we have equipoise.
That's a great point, Phil. I always remind my fellows and residents with regards to metrics, if we were to say at our hospital, we treat 1% of people with hypertension, or 1% of women who are supposed to get mammograms are getting them, or colonoscopies, anything that's preventive in nature, that'd be pretty darn bad. And that's where we are. So that may be a means to an end. I'm going to ask one last question. Obviously, a lot of people look up to you in our field. And right now, our fellows, it's been a tough couple of years, fewer cases, shutdowns, a worldwide pandemic, a saturated market. There's a lot of people out there who are thinking, boy, am I going to find a job as a bariatric surgeon? So I'd like you to tell us where you see the field going.
Yeah, I think just the opposite problem. Again, I have to, disclosure, I am an eternal optimist. Okay, so that's my disclosure.
That's why I asked you.
Yeah. So, but now look, obesity is not going away, not for a while. We haven't scratched the surface on any sort of preventive strategies. And ultimately, that's where we need to go. We need to sort of prevent the disease, but that is much more difficult to prevent a disease and to treat it. So it's going to be with us for a while. And you know what, Adrian, it's going to be, what's going to drive this? It's going to be the economics of it. It's obesity and diabetes are the most expensive diseases, in part because it's not going to sound right, but because they don't kill patients immediately. What they do is it's sort of a slow, torturous death. Especially diabetes, it's just one toe, one foot, heart attack, stroke at a time, and each one of those events is very expensive to treat. And sooner or later, the payers are going to figure out, look, if we don't treat this effectively, the root cause, which is obesity, diabetes, then we're going to be paying, we are paying so much more downstream. And they're beginning, there's already a number of economic studies that show this, And the other factor is our operations becoming cheaper. When I started doing the surgery, we started out doing them open, and then in the late 90s, laparoscopic, that dropped the cost quite a bit. And we've gotten better and better and better. And the cost, a sleeve gastrectomy is easily less than $15,000. Some places you can do less than $10,000. And gastric bypass is not that far behind. So for an intervention that is $10,000, it's going to have a lifelong effect. The economics are going to drive this. So I'm not worried at all. The future is going to be bright. Is there going to be a magic drug? There are some interesting drugs, but you know what? I'm excited. I hope, bring them on, because they're just going to expand the field. And none of those drugs in the near future are going to have the same effect that surgery has. Our medical colleagues, start dancing in the street when they have a drug that has 5-10% weight loss. Okay. Some of us would consider that almost borderline failure for surgery. Okay. So with surgery, we're seeing 30% weight loss, and long-term, very well sustained weight. So they haven't shown that with any of the drugs. They haven't shown that you can sustain weight loss 5, 10, 15 years like we have with surgery. So surgery is going to only grow in demand. We don't have enough surgeons. We'll need to train a lot more.
Phil, I can't thank you enough. I'm going to pass it back to Judy for some final comments. Thank you so much.
Great. Hey, Adrian and Judy, just one more thing. In my talk, I did leave my email and also my Twitter handle. So all of you fellows out there, I definitely need more friends to follow me. Okay. Occasionally, I will tweet something that has words of wisdom. So please follow me, and also if any questions about the field, feel free to email me directly. Okay.
No, I definitely cannot top your inspirational answer. That I'll sign up for fellowship again, right? Like that's again the wonderful part of our society, and I thank you for this fantastic lecture and the opportunity to really be able to know your experience, and thank you again. What a wonderful start to our new year, right? So I appreciate, and I hope the fellows really take the opportunity to reach out, because I think this is such an opportunity that you're here today.
And one last thing, Judy, if I may, Hey, a lot of us in 2020, it's been a depressing year. This COVID thing, it's had a negative effect, on getting access to surgery. And, I'm recovering from COVID right now. Got a couple more days left of quarantine. So it's been rough for all of us, but it's going to go away. It's going to end in 2021. Don't know quite when, but, we always look for silver linings, and this is just a good life lesson. When you go through tragedy, there's always lessons to learn, right? And so one silver lining is obesity. The COVID is going to shine a brighter light on obesity, because it's quite clear now obesity is one of the major risk factors for not only acquiring the disease because of an impaired immune system from this chronic inflammation state, but it's also a very negative determinant of the outcome. And so I think more attention by payers and physicians and patients are going to go to this, which is going to highlight surgery more. And the last thing I'll just say, there's been a couple of really interesting papers published. One recently by my colleague Ali Aminian at the Cleveland Clinic, just published in SWORD, showing that at the Cleveland Clinic, patients who are COVID positive, those that had surgery compared to a matched group who didn't, had a lower rate of hospitalization, a lower rate of ventilation requirement, lower rate of death. Yeah. So that suggests, not proven, but it suggests that surgery may be protective for COVID. So I think that's a very good thing for our field.
So I love your optimism, because that blessing there, I think, is the best way to look into our new year moving forward. So absolutely great discussion points. Thank you.
Great. Okay.
Thank you, everybody.
Please stay healthy, Dr. Schauer.
Thank you.
I'm glad you're recovering.
Okay, all of you guys too. Take care.
Happy New Year to everybody.
Happy New Year to everybody.